Thank you for inviting me to panel discussion of the clinical cases. So I'm presenting some interesting cases manifesting some of the clinical features which are commonly seen in ASD subject. Not all of them are diagnosed as autism, but there's a very similar symptoms and the common clinical presentations. Then these patients really took me a long time to properly manage it, partly based on the clinical assessment, immune workup, and some genetic workup. So these cases might be interesting to other panelists or parents. So I decided to discuss these cases. Hopefully, these cases are interesting to the participants. Okay, and so essentially for the motivation of my motivation to present these cases, essentially based on these two factors. Many biologics and immunomodulating is available and potentially helpful for treating ASD subject who has appear to have the immune abnormalities or immune mediated inflammation. And also the biologicals developed so many biologics. They have the very specific actions. Then also the immune abnormalities found in the ASD are likely to be affected by multiple genetics and environmental factors. Therefore, I think it's really precision medicine. Each patient to be carefully evaluated and then carefully selected for the treatment options. I don't think, probably everybody knows, but I don't think the one-size-fits-all approach probably doesn't work for ASD subject. So, case one, this is more like a patient with ESES and some ADHD and developmental issues. So initially he presented in our clinic at 6 years of age because of the treatment, the resistant or steroid-dependent ESES. And he was diagnosed with ESES at age 3.5 years of age with the onset of the clinical seizures. And it's really classical video EEG pattern with continuous 90 to 100% diffuse epileptic pattern, and which is those in association with abnormal video EEG. He has speeches affected, ADHD affected, behavior symptoms, especially ADHD-like symptoms. And he has been somewhat the clinical response to the oral corticosteroid, although his video EEG pattern are pretty much persistent. And mom is actually the physician, and she tried to reduce the oral corticosteroid. But if it's going down like 5 or 6 million per day, his behavioral symptoms recurring. So it has been very difficult to decreasing a steroid, and as a result, he has very affected by the prolonged use of the steroid, and especially his growth has been a concern. When I saw him, his height is less than 1 percentile, and at that time he was also has been on the multiple seizure medications. Seizure medications had tried. And at the time of the presentation, he was on Vimpat, lacosamide. And because of the prolonged course of steroid and the multiple seizure medicine use, initially we worked up for the impaired humoral immunity. The reason why that the patient like this, we often see the low immunoglobulin levels, and that makes it very difficult for us to use as an immunomodulating agent that are often immunosuppressive. And as expected, his IgG levels are very low, below 2 standard deviation of the age-appropriate control, and IgA, IgM is like a low normal level. So we started for the subcutaneous immunoglobulin. And again, this is a seizure kit. And in my experience, a lot of the patient with seizures, if we give the IVIG, they tend to have the seizure clusters. So we have to give the very low dose frequently, but I found it much safer to give subcutaneous because it's weekly, small dose, and it's not going to causing the rapid rise of the serum levels immunoglobulin. So we started a sub-Q immunoglobulin. He didn't like it because of the needle, but no seizure clusters. So he tolerated well, and it's like a less infection, like a ear infection, sinusitis. So that is good. So then mom wanted to try the Epidiolex, and it may calm him down and essentially the less hyperactivity, but there is no change of his video EEG activity. And so because very similar patient we had, one case which I reported before, we did a good improvement of at least video EEG finding. So we started sirolimus slowly. And somehow it took us a long time to adjusting the target level of the sirolimus. And he may have a little bit absorption issues of the sirolimus. And I think this is partly because of the use of the change of the gastric acid steroid and the PPI use of the H2 blockers or the measures. And however, once you gradually reach, then it's more sustained, like a good sirolimus levels. He became able to taper off oral steroid. Mom tried very slowly and per endocrinologist recommendation. And I think it's just the last month he was able to off steroid. And he completely lost his crushinoid features and started to grow a little. And it was really and mom was very excited in the last month because last month's most recent video EEG, it was pretty, mom thought maybe 90 to 100%, and the other neurologists so pretty normal. So essentially, no doubt, the video EEG was very good. At least for the two neurologists agreed that the marked improvement of the video EEG, which is very encouraging. So his case, although we didn't have any a genetic workup, so, and he did have the, I didn't show it, but he did have a little increasing of the altered, skewed, inflammatory skewed cytokine responses, despite he was on the steroid. Probably the sirolimus and gatekeeper blocker was very effective in his case. But again, it doesn't necessarily mean sirolimus works every ESES patient. But his case was very effective, so this is one case. And these diffuse diffuse ESES-like seizure activity, there might be very Theorems type mTOR blocker or other, like new ones, which probably very hard to be approved other than TS patient. mTOR inhibitor may be a good promising therapeutic option. Okay, and this is like a case 2. This is not a really autism patient, but has very striking anxiety and also anxiety OCD-like symptoms. And she was initially presented in our pediatric allergy immunology clinic because of the low IgG1. But 1 year prior to the presentation, she was diagnosed with PANS at another institution. Then she was initially managed by the intermittent oral steroid, also intermittent some antibiotics, and some responses. But because of the low IgG1 and the recurrent respiratory infection, she was referred to our clinic. So initially, we treated her as like a IgG1 deficiency, and IVIG every 3 weeks was approved as a supplemental dose. Then he has a good improvement or better management of the recurrent respiratory infection, and consequently much less neuro fluctuation of the neuropsychiatric symptom. However, at age 15, she developed severe abdominal pain and bloody diarrhea, and diagnosed with Crohn's disease, which is based on the histological finding by colonoscopy. So, but he was, her manifestations of Crohn's disease is little atypical. She was initially treated oral steroid, then the anti-TNF-alpha inhibitors, initially Humira, and then tried on the Remicade. Part of the reason is with Humira, she still has some abdominal symptoms, so switch to the Remicade. But also, even CD region appear to be better with colonoscopy and with the use of anti-TNF-alpha inhibitors. She began to suffer from severe headaches, fatigue, and more significant neuropsychiatric symptoms, joint symptoms, worsening the postural orthostatic tachycardia syndrome. And also, beforehand, about 5 years, she has no adverse reaction to the IVIG, but after starting TNF inhibitors, she started to have severe adverse reaction to IVIG, headache, joint ache. And so, those symptoms made us wonder if she has any kind of the abnormality, atypical or altered immune condition. So the initial immune workup more stood out for the increase in IL-1 beta production by monocyte. Then we did the initial target gene sequencing, and then result is a little inconclusive. We went ahead to do the whole exome sequencing in the patient and the parents. And 2 things, she did have the she was found to have a carrier of the ATM pathogenic variant, but it's a heterozygous and autosomal recessive. So I think she's just a carrier of the ATM gene. But the 2 autosomal dominant gene mutation, which may be as a polymorphism. And one is NLRP12, minor allele frequency is 0.04%. So might be considered to be more polymorphism. Then another IRF2B P2 mutation, which is a much less common mutation. And it's an autosomal dominant, but clinical significance is still questionable. The NRLP12 is a suppressive mutation, a suppressive protein of the inflammasome. So this is like a gain of the loss of function mutation. And if this suppression is lost, she's expected to have the increase in IL-1 beta and TNF-alpha production. And there is a 2 patients reported to have the exact same mutation she had. In these 2 patients, they manifested like autoinflammatory type syndrome. And IRF2B2 mutation, which is only recently reported, the gain of function of this mutation causing excessive suppression of the B-cell differentiation and the other cytokine productions, including TNF-alpha. And so this is at least this gene is reported in a few cases of the CVID, essential immunodeficiency syndrome. So what is the treatment option with this information? So we hypothesize because of the TNF-alpha inhibitor, because of the mutation she has, she may has more cytokine production shifted to the excessive IL-1 beta production. So we discontinue the TNF-alpha inhibitors because these are all monoclonal antibodies. We waited for at least 8 weeks to do adding any other immunomodulating agent. Then starting the low dose of IL-1 beta blocker. And we used anakinra because if any kind of changes, anakinra is a short action. So that we can either stop or change the values, change the dose very quickly. And also, he was so miserable with IVIG treatment, we discontinued it and decided to monitor immunoglobulin levels. So after starting the IL-1 beta blocker, this is not a very high dose we use for the seizure case, or they usually need 200, but it's just 100 milligram anakinra. She showed a marked improvement of the joint ache, headache, and all the general fatigue. But they may still have some pot symptoms. Then occasionally she has a little worsening, like GI symptoms. And so in that type of the condition, we decided to give a very short course of the low dose steroid. And so in this case, probably the 2 different mutations almost acting exerting the antagonistic action may have somewhat balance. And actually these 2 gene mutations are coming from her father, but her father has clinically doing okay, although he has some mild GI symptoms, some mild joint symptoms. And it might have been a little bit, those balance was altered because of the Crohn's disease and then also the TNF-alpha inhibitor use. So this is a kind of the case. So we need to know the more genetic background and also and it's really the need for this case is illustrating the need for the individualized, like precision medicine. Okay, and this is for and one of the reasons we have to check how the change of the cytokine production. The 2 NRLP12 mutations reported. Actually, these patients, when they try the IL-1 beta blocker, because IL-1 beta blocked, then it's only TNF-alpha result, TNF-alpha productions increased. So actually, they couldn't some of the symptoms got worse again. So we checked after like 5 months after the starting anakinra, if the same thing happened or not. We checked for TNF-alpha production and iron. And the good thing is she didn't show any increase in TNF-alpha production, and iron beta production did decrease, IL-6 production decrease. Regulatory cytokine like IL-10 or soluble TNF receptor didn't change. And this is like IL production under the culture of the beta culture, under the culture stimulated with beta-glucan. And beta-glucan is an inflammasome. It's a specific for the inflammasome activation. So I think in this case, the presence of another mutation, which is suppressing the TNF-alpha production, maybe it's prevented for the overproduction of TNF-alpha when we used for the anakinra, one of the iron beta blocker. Okay, so this is the third one is like we still are working on. It's still not completely conclusive, but it's really the very puzzling case to me. So I'm presenting. So actually this is the 2 cases, and 2 Caucasian male siblings, then presented with recurrent infection, high anxiety, OCD, persistent joint ache, severe fatigue, and weight gain. Actually, the older one getting gradual weight loss. Both have some ADHD type pictures. At least younger ones diagnosed with like high functioning ASD with age advanced IQ levels. Mom thought the older siblings also have ASD, but the assessment was a little inconclusive. And they didn't respond to any antibiotics because of the slightly low immunoglobulin levels. We tried the prophylaxis antibiotics, but they didn't respond. And their anxiety is so high, we tried the beta blockers, and there is no response. And also, they are treated by psychiatrists. And they are tried on the multiple common, like SSRI, mood stabilizer. Those common neurotropic medications, there's no response to those medications. So the younger sibling was generally a low monocyte cytokine profile. It's almost like a kind of the consistent the data we see the specific antibody deficiency patient. And we did check for his immunoglobulin level is low, but it's not particularly not severely low. So we checked for the PCB13 response, and he didn't respond so well. So he is qualified for the IVIG treatment under the diagnosis of specific antibody deficiency. His level is a little too high to be diagnosed with a CVID. And he did actually better. His fatigue, infectious control is significantly better with IVIG, but for the, and subsequently, he's feeling better. But still not complete. The other sibling, which has actually the much higher increasing the IL-1 beta IL-10 ratio, and then which is associated with a marked decrease in the IL-10 production, which is usually a little atypical, because usually when the ratio is increasing, high IL-1 beta, then a little decreasing IL-10. The patient in the like a PANS-like patient was GI symptoms. I mean, in ASD patient with GI symptoms, or the pants-like symptoms. So because in this case, I couldn't get to the approval of the whole exome sequencing, I opted to do the PID, primary immunodeficiency target sequencing, which was covered by his insurance. So at least in his case, it was found that he has the autosomal dominant mutation of the COPA, and which is really one of the causative genetic mutation of type 1 interferonopathy. Essentially, the overproduction of the type 1 interferon, like a kind of BCG type innate immune memory induction, and causing a lot of interferon gamma or in type 1 interferon dominant immune abnormalities, or those interferon dominant inflammation. So we tried to starting on the JAK inhibitors because type 1 types of interferons downstream signaling is Janus kinase, and that like a STAT1, STAT2, STAT3, and then downstream is a JAK kinase. And JAK kinase, the first generation was blocking what type 1, type 2, and I'm sorry, the JAK1, JAK2, and JAK3. And but for the, so we tried the first Zelzant. Zelzant is like a first generation JAK inhibitors. And he did a little better, but it's not completely. So probably, ideally, he's better to be tried on the second generation JAK inhibitor, which is mainly just blocking JAK1, JAK2. So this is just for the downstream of the signaling of the type 1 interferon, like a type interferon alpha, beta, lambda. I think he's a good candidate, and actually one case of the COPA syndrome reported was a good response to the second generation JAK inhibitor. However, still very expensive. So I hope to get the insurance approval. So this is a little struggling when we try to use the biological, especially the newer ones, off-label use. So this is another case of the different type of the inflammatory pathway. So that depends on what type of the inflammatory pathway is affected. The appropriate immunologics are necessary. So this is quite a different case, and I just wanted to show that what type of the biologics are necessary. It really depends on the patient. Okay. So this is the end of my case presentation. And thank you again for inviting me to the panel discussion.